Whoa, natural gifts. I think I like people, so there are real limitations to these exams. The new exam is being piloted at the moment. What I like about it is that they are really looking at things from ground zero, blue skies thinking, trying to reimagine it, reimagine the marking schedule. We've done some research a long time ago in 2014 with a sociolinguist that appeared to show that there were issues with the interpersonal skills domain. A few years ago, I was at the University of Surrey where we were putting in a bid for a new medical school, and we didn't get it. This was in 2018, and it felt catastrophic. It felt awful because everybody knew that we hadn't got it.
Welcome to this new episode. Today I'm joined by Professor Kamila Hawthorne, a GP who has broken many ceilings in her career. She is the first South Asian woman and first working GP in Wales to become chair of the council. Thank you very much for accepting this invitation, Professor Kamila Hawthorne. Could you please introduce yourself for people who might not know you?
Yes, of course, and thank you for inviting me, Owen. So my name's Kamila Hawthorne. I am a GP in Mountain Ash in the Welsh Valleys. And up until recently, I was also head of the graduate entry medicine programme at Swansea University. So I'm also an academic medical educationalist. I'll be starting as chair of RCGP Council in the middle of November for 3 years.
I'd like to congratulate you again on your milestone of becoming chair of the RCGP. One of the things that you said was there's still an awful lot of work to be done to improve equality in medicine, particularly for women and international doctors. They're saying that you can't be it until you see it. Carries some weight. I hope my election will inspire other GPs. What is your vision for general practice?
My vision for general practice is I hope it's not utopian and is actually achievable, that in the coming years, general practice will expand in numbers and also enable us to see patients at a reasonable rate, because at the moment, it's just way too busy to be able to be even considering yourself to be safe with patients. So my partner yesterday in Mountain Ash was on call. She saw 69 patients yesterday, and that really is rather a lot of people. So we've got to change that. Will I be able to change that on my own? No, of course not. But I will at least have my voice heard in this position, and I may be able to influence people who can also make changes that will enable us to work in a safer and more job-satisfying manner. I see us working with multi-professional teams. I see us actually providing more services than we currently do, because many of those team members can do things that we can't do very well. So, for example, if we had mental health nurses, physios, OTs, all as part of our team, then they can do quite a lot more for patients than we do as GPs. But I would still see us as leading that team and being the key members, really, of the team, the glue that keeps it all together. My further vision, of course, is an upgrade of many of our premises and our telephony system so that patients get to access us when they need to, and they get to see the right person at the right time for the right thing. I think that's the mantra that other people have been using, and I think that's right. I think that's completely right. It shouldn't always be the GP that they need to see. And at the moment, I see a lot of patients who really didn't need to see me. They needed to see somebody else in the team first. So at the moment, then, if we are increasing our multidisciplinary teams, we're going to need bigger premises. If we are going to be training more GP trainees and more medical students, then we're going to need bigger premises. And if we're going to make sure that we get good access for our patients, because after all, that's what we're there for, then we need much better telephony services so that patients don't have to wait for hours in order to be answered. So this morning, I was trying to get a GP telephone appointment for my mother, who's just fallen quite badly. And I waited 25 minutes before the phone was picked up. You know, that's really not acceptable. It's just way too long for patients. We're not able to give them a good service with the type of quantity of work that we're currently having to deal with. The workload is really just extraordinarily enormous.
The future of general practice looks quite challenging the years ahead, with a very difficult workforce dynamic where we're seeing more GPs considering early retirement. So in terms of the practicalities, what do you think are the things that you want to make sure that you get done during your term? Because there's a lot of things, and I understand that you want to go and change a lot of things, and you're also very sensible in what you can achieve in the terms that you've got. What are the few things that you want to make sure you get done?
So it is a 3-year term of office, which actually 3 years goes very quickly. I've just been to the Conservative Party conference, not my natural habitat, I must say, but very interesting to go there. And I've come away, in addition to all the confusion that's going on in the Tory party right now, with a very clear message that there will be no new money for health or for general practice, really, as part of health. And so my feeling is that pragmatically, we've got to work with what we've got. We've got to try and use what we've got even better than we currently do. And I think that there are things that we can do. I know that the GMC has just announced this morning, because it's been in The Guardian, that they are pushing for specialty doctors in secondary care to be able to work in primary care as well. Now, yes, that may help with the numbers game. Those 6,000 extra GPs that we were promised are not appearing anytime soon. But we don't want to dumb down the standards of primary care. We've got a lot to be proud of in general practice, a lot to be proud of in our MRCGP curriculum and in our exam, so that we are bringing doctors up to a really good standard of primary care delivery before we allow them to practice as GPs. So I really think that as a college, we need to get in there quick and talk with the powers that be about how we are going to make sure that these doctors coming in, because I think it's going to happen whether we want to or not, these doctors coming in are of good enough standard and are being properly supervised, and also that they're not going to be exploited. We need to make sure that they're looked after, that they're valued and welcomed if they're coming into primary care. I have the feeling that it's going to happen, as I said, whether we like it or not. And I much prefer to work with NHS and GMC and HEE than to have it done to us. I think it's better, it's much better, and we'll get a better deal out of it. So that's one thing. I also think, that as a college, one of our special attributes, if you like, is that we are a membership organisation. We've got over 50,000 members. And I know that amongst all those members who are all working, well, they're all GPs, that some of them have found solutions to the problems they've been facing. Some of them really innovative solutions. The problem is that we don't know about them all. One of the things I'd really like to do is to use our membership networking capacity to actually bring to the fore some of these innovative solutions, not necessarily the solution to everything, but maybe a solution to one type of problem, so that other GPs can see what's been done elsewhere and maybe then contact that person and say, how did you do that? We're also having this problem. How did you do that? Can you advise us? And I think that way we help each other and share good practice. We get an opportunity to celebrate good practice and be proud of the people who are doing amazing things, as well as helping people who are still struggling. So I think there's an awful lot there. The college also has a small group who help struggling practices. Initially, it was formed to help practices that were in special measures with CQC, but it's now started working further upstream with practices that are starting to struggle, and has moved, working mainly in England, has just recently moved into Wales. And I think, again, if we've got a system where through our membership, we've got ideas of things that other people have done, this little group may also be able to use some of those ideas to help struggling practices that they're working with as well. So you can see how my mind operates. I like to start in a small place and then build on it and build on it. Very keen on networking, very keen on us talking to each other, communicating and working together.
That's great. Yeah, I think collaboration is key to how we're going to find solutions in the future. And one of the things that GPs have been saying is that there has been a broad divide between primary and secondary care, and this work that's transferring without funding being actually followed. So what do you think things that we can provide solution to make sure that there's a better collaboration between primary and secondary care?
Many people are working on this area because there's no doubt that a lot of chronic disease management, for example, has moved from secondary care into primary care with no resources following it. We need to negotiate on that. We need to also talk about how our secondary care colleagues work with us and how we work with them. There are things we do that really irritate them, and there are things they do that really irritate us. And I think this is again about communicating and setting up contracts and agreements. I know that Jonathan Griffiths up in Merseyside has been working on this. He's a member of RCGP Council, and he's somebody that I'll be talking to, in the coming months to see how that's going, and see also whether we can disseminate some of his work across the country. Because, why reinvent the wheel? If somebody's doing it already in Merseyside and it's working, well, let's promote it and use our networks to make sure that other people know about it too. The other thing that I think we need to be thinking about as a college is our multidisciplinary team members, our allied healthcare professionals, who at the moment don't really have professional homes in primary care. And I think that we should, as a college, be thinking about how we offer them some kind of professional home within the college, not necessarily membership as such, but some form of associate membership or an academy of primary care that they can belong to, so that they can also have access to our resources and work with our networks and teams, come to our conference, that sort of thing, so that they can stay up to date, they can learn more about working in primary care, and also get to meet each other and build their own networks.
I want to switch gear here about your personal story, how you actually decided that you were going to put yourself to become chair, because this is quite a huge commitment on yourself.
It is, isn't it? And sometimes I think, why have I done this? I suppose it all started about 20 years ago. I was an MRCGP examiner. We were based in Prince's Gate in those days, near Hyde Park. And I was up at the college examining when I had a message from the Honorary Secretary, who was then Maureen Baker, saying that she wanted to see me. And I thought, oh dear, what have I done? Have I done something wrong? But I went to see her, and she was very sweet, very nice. And she said that she thought I should consider standing to be a nationally elected member of council. Now, the idea had not crossed my mind at all, but of course I was very gratified that somebody had noticed me and somebody had thought that maybe I could do more than I was doing already. And so, in fact, I did stand for election, and I didn't get it. But that didn't put me off, and I ended up as a faculty rep for the South East Wales faculty, which is where I live. I live in Cardiff. And so I did end up on council as a faculty rep to start with for a few years. And a few years later, a role came up as vice chair for professional development. That was in about 2014, 2015. And I stood for that because professional development, medical education, that was very much where I was already in the other work that I was doing outside the college. And I was elected and was vice chair between 2015 and 2018 when Helen Stokes-Lampard was the chair. And at that stage, I remember looking at Helen and thinking, no way do I want to be chair. That is just too exposed. So it is funny, isn't it, how people's thought processes go. And, a few years later, I was thinking, well, actually, Helen does that really well. Well, I want to have a go at that too. So I stood for chair in 2019 against Martin, and I didn't get elected. And of course, it's very disappointing when these things happen, very, very disappointing. And I came away and found other things to do for a few years. That's when I took up the job in Swansea as head of graduate entry medicine. And actually, I had a lovely 3 years in Swansea, really enjoyed it. Really loved the students, loved the staff, had a great opportunity to fiddle with the curriculum, put lots of general practice into it, lots of community-based learning, as well as some public health and epidemiology. Really enjoyed myself. And then, of course, the post of chair comes up again for election. And I'm still a member of council because I'm now on trustee board. And I thought to myself, well, this may be my last chance. So go for it. And, you know, if you don't get it, fine, you dust yourself down, you pick yourself up, you move on. You know, that's how it is. And I've often sort of looked at politicians who fail elections again and again and just keep trying, and one day they get elected. And I thought, okay, you know, it's not personal, it's just the way it is. And maybe 3 years ago, I just wasn't the right person. Maybe I didn't look right, who knows? Maybe this time I will be the right person. And of course, that is what happened. And so that's how I got elected, and that's how I am now eagerly waiting to take up the position next month.
Yeah, I can see you have this dynamic energy with you that you want to go and change things. And I have to acknowledge your relentless pursuit. And even if you've had times where you were not successful, you kept going at it. And that's something that says a lot about your character. So tell me, what are your natural gifts? What are your strengths, Professor Kamila Hawthorne?
Whoa, natural gifts. I think I like people. I like working with people. I'm not somebody who wants to do everything on my own. And I love finding what it is that another person really wants to do, and then finding a slot for them in doing what they really, really want to do. And it is just so fulfilling, really, to be able to do that. And more and more, as I've become more and more senior, I've been in those positions where I can talk to people and find out what they really love doing and then help them to do it. I think that I'm also very lucky in that I have a very supportive family and a very loving husband. And so my home life is stable, which I think means that I've always got that to go back to. And funnily enough, I think also my basic medical training has really helped me when it comes to times of difficulty or stress or failure. Because, you know, a few years ago, I was at the University of Surrey where we were putting in a bid for a new medical school, and we didn't get it. This was in 2018, and it felt catastrophic. It felt awful because everybody knew that we hadn't got it. And, you know, initially after the first few days, I thought to myself, hang on a minute, I haven't killed anybody. I haven't cheated, I haven't lied, I haven't done anything wrong. It's just stuff. And stuff happens sometimes. You just got to get on with it. And you know, I felt so much better. So much better. And I think that is very much a kind of, you know, your basic doctor's instinct is, you know, you put your patients first. You know, the last thing you want to do is to hurt somebody. So, you know, and then transcribing that into this situation of failure and saying, hang on, I haven't killed anybody, I haven't hurt anybody, I haven't done anything wrong. This is just bad stuff that's happened. And that's really helped me as well, being sort of fairly pragmatic, I think. What other skills? I think it's the networking actually, and the ability as a generalist to see connections, maybe where specialists don't see them. That's really helped with building curricula and, you know, bringing interesting new things into a curriculum. Nothing much frightens me. You know, I a bit of obs and gynae, I can do that. Bit of peds, I can do that. Bit of neurology, no problem. And that, I think, is, of course, the special thing that we have as generalists.
Yeah, I think journalists can see the bigger picture and are able to make the connection, and that's a great value as journalists and practitioners we've got. So I know that you have been in education and you're still in education, and you've also been an examiner. One of the things I'd like to talk about is the changes with RCGP exams. So there was a CSA that was introduced and then changed to the RCA, and then now there is pilot for a new CSA coming. What are your thoughts about the exam to be able to assess the standard of a GP to go and practice independently, and what do you see in the future?
The mantra for the MRCGP exams is that people who pass the exam have been shown to be safe practitioners capable of independent practice, and of course as a GP that is so necessary, isn't it? Because it's quite difficult to get second opinions or to get somebody to supervise what you're doing, as you might do in a hospital setting. I think that the the old MRCGP, so pre-2007, when you didn't have to do it unless you wanted to, was a very different animal, really. It was old-fashioned, it was based on vivas, it was based on handing in videos, which actually, funnily enough, then comes back as the RCA, and written papers, some of which were really very old-fashioned written papers. It did need a change. Moving into what we used to call the new MRCGP, but that was in 2007, so maybe not so new anymore, meant that we started using much more modern systems of assessment, OSCE style, simulated surgery style, CSA, as well as the AKT, and the work-based assessment was new because we didn't really have that before in the membership exams. I think we always thought that if work-based assessments could become good enough and reliable enough, we could dump the CSA, get rid of it. But unfortunately, the work-based assessment has never become reliable enough. It's unwieldy, it's difficult to do, it's needing to be sure that enough different people are assessing that particular trainee so that you can reliably say this person is capable, is safe, can work independently. And that's still a work in progress that we still need to be working on. In the meantime, the CSA, when it first appeared in 2007, seemed like, the best thing since sliced bread at that point. And it wasn't really until the first few years came and went and we started looking at the stats that we realized that there was a big discrepancy in differential attainment, which actually was quite shocking and very upsetting. Both my parents were international medical graduates. I'm not, but I've lived my childhood in East Africa, so I know what it's like to come from one country to another and try to assimilate and settle into a new culture. And that was just terribly upsetting, and the more we looked at it, the less we could see that we could do as an exam. We had fairly broad diversity of examiners, and role players and cases were quite diverse. Of course, they all were delivered in English. We had a long discussion about what if you did a case in Polish, or if you did it in Urdu or some other Gujarati, some other language. But then, there'd be some candidates for whom it was their first language, and so everybody else would say they had an unfair advantage. And so we stuck with English. We did try on one or two occasions, but it just didn't work. And then, of course, COVID hit. I think the college did a marvelous thing, switching to the RCA so rapidly so that people could continue and, graduate as GPs, because otherwise they would have been absolutely stuck. So that was amazing. However, in itself, the recorded consultations as an examiner, at first, I just loved watching them because they were so real. The patients were so real. But then you start seeing all the kind of hidden curriculum of exams creeping in, the formulaic statements, the eye on the clock all the time because you've only got the 10 minutes. All of that then forces candidates into doctor-patient behavior that just isn't particularly good necessarily. As when you're in a real practice, some consultations may take 8 minutes, others may take 12 or 14 minutes, and then you can vary them. So there are real limitations to these exams. The new exam is being piloted at the moment. What I like about it is that they are really looking at things from ground zero, blue skies thinking, trying to reimagine it, reimagine the marking schedule. We've done some research a long time ago in 2014 with a sociolinguist that appeared to show that there were issues with the interpersonal skills domain of the exam, because of course it leaks into both the other domains, the data gathering and the clinical management. And if you are not doing well in interpersonal skills, you tend not to do well in the other two. And I think, again, they're looking at ways of putting less weighting into the interpersonal skills and more into the clinical management of the exam. It's going to be really interesting to see what effect that has. And I really, really hope that that will reduce differential attainment. I suspect it won't clear it away completely, because some of the issues lie in the training and training opportunities that people get. But hopefully it will make a difference. I really hope so.
Yeah, I think the differential attainment is quite surprising when you first look at the data. There probably are multiple factors that contribute to this. And a lot of doctors who are trying to get through the exam, they find it really disheartening, especially when they don't get specific feedback about what they were not doing right. And also the fact that they might think that they're doing something well, but actually, when we look at the consultation, there are things that maybe they don't understand.
So I think when people do these exams, they usually want, in terms of feedback, to be told exactly what went wrong in each case. And that just never works because you're never going to get the same case again. So there's no point trying to learn what you did wrong in that case, because next time you do it, you'll get different cases and you'll do different things. So I think that's just a kind of misunderstanding, really, in exam technique. The feedback that we provided in the CSA was fairly generic, I agree, but there were quite a number of feedback statements, and behind each feedback statement was a long explanatory note. And of course, what we wanted was for people to think of in general terms of what they were not doing well. So if it was that it was disorganized time management, that's a kind of general thing, so that you then work on that in your practice for the next sitting of the exam. Is how you manage your time during consultation. And we could certainly see it in the sociolinguistic research that we did, where we would actually map exactly what a candidate did during a case. And we got 200 candidates to agree to allow us to video and record and keep the recordings of their exam, their actual exam. Of course, we promised that we would anonymize it, and we never showed any examples of bad practice, never. But we looked very carefully and mapped exactly how that each consultation went. How much of those 10 minutes did you spend in data gathering? How much in clinical management? How much in anything else? And you could see disorganized time management just in the color coding. So it is. So some of that feedback was just very useful. Really, it's really more about learning how to use that feedback, to your own advantage, rather than a specific thing. In such and such a case, you should have said this. That doesn't really work as a way of learning.
So, in terms of the feedback that candidates receive, it's more of a trend that they can see what they need to improve on, rather than like a specific thing that focusing on one case. That's the idea of this type of feedback that's been given.
Yes. So, and it also means that examiners can put a fair bit of thought into the feedback they give, because they've only got a minute or two between each case. And to actually handwrite or type case-specific feedback for each candidate, the exam would last for much, much longer because they wouldn't have time to give you good feedback. You'd only get a word or two. In this way, you get a lot more.
And I think the college has been very good at listening feedback from trainees, and there has been an extension to 12 minutes for the RCA. And it looks like there's going to be a hybrid model where there's going to be the benefits of the CSA and the RCA combining together to find out what's going to be the next exam.
Yes, I think so. I mean, it's looking as if it's going to be a virtual exam rather than a face-to-face exam. And so hopefully trainees will be able to sit the exam in their own surgery, surrounded by their own things, because when you are in the CSA suite in Euston Square, everything is synthetic. The room is not real, the patient is not real, the case is not real, and then there's an examiner sitting at the back watching you. So, it's really difficult to concentrate on what you're supposed to be doing. And some people find it much more difficult than others. So I hope that this will feel more real. And also it means that if we ever, God forbid, have another COVID-style lockdown, we'll be able to carry on because we are delivering it virtually, not face-to-face.
So one of the things that trainees used to say when there was a CSA was that, it's so artificial, it's very simulated. But now when we had the RCA, the comment is now, people are just talking a lot, and it's very difficult with this consultation. But there's no perfect exam that will be able to find out. There'll be pros and cons for each.
Yes, whatever you do. Role players, however much we train them, don't talk as much as patients, and it's fascinating, isn't it? We do try to copy what patients say and give it to role players and say it like this. But it still isn't as much as what a patient would say. And yes, and of course the patients come with lots of different problems, don't they? So as soon as you finish with one problem, they want to ask you about another one. And you haven't really, what you want is one problem for one case. And that also makes life very difficult. I mean, the other thing about the new exam, which will be with simulated role players again, consulting virtually, is that the other advantage is that no longer will candidates have to travel to Euston Square, have to pay for travel as well as overnight stays and taking time out, and sometimes the weather is bad and the trains get cancelled and the whole thing just becomes really hairy. I remember once going for an exam when I was training down from Nottingham to London, and it snowed the night before, and it was absolute nightmare getting to that exam. I think by the time I got there, all my adrenaline had already gone. There was none left.
It does actually have a difference in terms of the preparation of that candidate. If they're coming from maybe like Aberdeen, going to London, where somebody who just lives in London, they don't have to actually wake up early or go overnight. So yeah, I think having remote is more convenient. And one of the things that I'd like to ask you is about the cost of the exam, because cost is something quite important. I understand that these exams do cost. What do you think are the options? Like in Wales, GP trainees have got their exams funded by the Welsh government. Do you think that there's any options for trainees to get some help with the cost of the exam?
I think it would be great if the other governments do the same. I mean, of course, I'm a Welsh GP, so I'm really proud that Welsh government does that, or that HEIW does that. So yes, maybe pressure needs to be put on, so that I think it's the first attempt you get for free, isn't it? And then after that you have to pay. So I think I would like that very much. I think our problem is that, of course, we're having to pay for the examiner's time, and as GPs and as independent practitioners that are not on a sort of hospital salary, it's not in their job plans, so we have to pay for them. And GPs are expensive, as anybody who's employed locums will know. So we're not paying at locum rates, actually. The daily rate for a GP examiner, for example, is just over £400. It's not a lot of money, really, by everybody's standards. But of course, it then raises the cost. Whereas in some of the other Royal College exams, they're using doctors who are salaried by their hospital trusts, and it's part of their job plan, so the college doesn't have to pay them for their time. So that's what really puts the costs up. I think that, come the new exam, so the new exam, there will be development costs, and trustee board at the Royal College has already agreed to fund some of those development costs. And the CSA suite will no longer be needed, so if that's decommissioned, that'll be some costs less. It'll probably end up round about the same cost in the future, because there's all the development cost of the new exam, plus you've still got examiners and role players that you have to pay for. And the college does go to huge efforts to make it cost neutral to them. So then they're not forking out for the exam, but neither are they making a profit out of the exams.
That's right. Yeah, I understand that. So, looking at your career, the fact that you've had so many challenges, and the fact that you've managed to get to a point where you've reached a very good level in terms of your leadership and management, and a lot of people, I think, would be inspired by your career. What advice have you got for somebody who is thinking, I'm not sure whether leadership is for me, or maybe they're thinking about medical education, the very early stage of their career? What would you say?
Well, it's the advice I give our medical students in Swansea, which is have confidence in yourself. To have got to where you are, you must be good, you must be pretty intelligent, you must be pretty resilient, and put one foot in front of the other. Be flexible. Look out for opportunities when they come, because often when they come when you least expect it, and be willing to take a chance occasionally. And remember that, if you fall down, you brush yourself down and you carry on. A long time ago as well, when I was a little girl, I had a story of Aladdin. Do you remember the story of Aladdin? My father used to tell me again and again. I was about 3, I think, or 4, and I knew it off by heart, actually. And if you remember, Aladdin has a lot of mishaps. And on one occasion, this book sadly was in rather awful poetry. But he's having a terrible mishap. He's having an awful time. I think he's lost the lamp. And at that point, the book says, "But brave Aladdin, though he's small," and then my father would look at me and say, "About the same as you, isn't the kind to cry at all, but thinks what he can do." And so that was my father using the book to give his daughter advice. So I think that's the best advice I can give to you as well.
That's amazing. Yeah, I like that story. Thank you very much for giving your time today to talk about your career development and how you actually thought about your vision for general practice and also the incoming exam as well. I really appreciate your time. And where can people find you?
Well, I'm a GP. I live in Cardiff. My email address is camilla.hawthorne@rcgp.org.uk, and I'll be at the college probably Tuesday to Thursday most weeks, working from home on a Friday, and in my Mountain Ash surgery on a Monday.
Amazing. Thank you very much for your time. Take care. Bye-bye. I'm curious to hear from you. What did you think of this interview with Professor Kamila Hawthorne? Let me know down in the comment section. If there's something that you agree or don't agree with her, then please comment down in the comment section. If you enjoyed this video, then drop a like for more videos like this. If you found this video useful, then you might want to watch this video where I discuss about portfolio career.